Hello, my name is Mike Peach. I'm a paramedic and external educator for Allina Health. And today I'm going to show you how to apply oxygen to a breathing patient, as well as use the BVM on a non-breathing patient. First and foremost, every time, BSI, is your scene safe? Which it is. We're going to go ahead and apply some oxygen. When you get a new oxygen tank, it's going to have a seal around the neck to keep it clean and keep debris out. We refill our own with just compressed air, so there's no seal. The reason it needs to be sealed is because you don't want anything to get in this outlet. If something such as a hydrocarbon atom gets on the high pressure side of your regulator, it could cause an explosion. And there's a real possibility for that because tanks are stored in outside compartments. There can be flares, motor oil, all kinds of hydrocarbons in there. So you want to make sure this is clear before you put your regulator on. By doing that, point the opening away from you and give it a good crack. That'll blow out any contaminants or anything else in the opening. Now to put this on, there's a pin system. There's two little pins here that go into two little holes on the neck of the tank. You match up the pins to the holes, and that's the key with any type of gas administration system. The pin configuration on this oxygen regulator will only fit an oxygen tank. So all you do is slide it over the top until you feel the pins drop into place, and tighten this by hand. Righty-tighty, lefty-loosey. Now we're going to turn it on and check for leaks. And we don't hear anything, so there's no leaks. If it was leaking, you'd hear something like this. But there's no leaks, so we're good to go. There's about 1,000 pounds in this tank, so that's adequate. At about 500, you're not going to want it. You're going to refill it. So we've got our conscious patient. He's been evaluated. He just needs some oxygen, so we're going to get this non-rebreather. Hook it up to the nipple. Don't push it on too hard because they're really hard to get off. And run this about 10 liters. A mask at 10 is really easy to remember. The range on it is like 6 to 15 liters. Anything above 10 isn't going to do your patient any more good. You're just going to run out of oxygen faster. So talk to your patient. All right, sir, I'm going to give you some oxygen here. Just breathe normally. Put this over his head and fasten the strap. And you can tell if it's working properly if he fogs up the mask when he exhales, and you see the bag deflate when he inhales, you're good to go. All right, so you begin transport. You check on your patient. He looks kind of still. His color's maybe a little off. You look at him and he appears to be not breathing. So anytime you come up to someone and you want to evaluate them, you do your responsiveness check and ABCs. Sir, can you hear me? No response. He was conscious. So you're going to tip his head back, look down his chest, look for rise or fall, listen for air exchange, and feel on the side of your face if he's moving any air. He is not. So we're going to check a pulse, 5 to 10 seconds. You can't be too quick. You don't want to miss anything that's weak or slow. And he has a weak pulse of 60. So we're going to check his airway. We look in his airway this time and it's all full of vomit and secretions. So you grab the suction unit, make sure it's working, control his tongue, and insert this only as far as you can see, no farther. Suction on the way out. If you suction on the way in, it's going to stick to the tongue and everything. Go until you're clear. It looks clear. Then we're going to give him an OPA, oropharyngeal airway. They come in a lot of different sizes. The way you size these up is you measure from the earlobe to the corner of the mouth. And if it reaches that span easily, that's the right size. Anything smaller, when you insert it, it's going to poke into the tongue. Anything larger could stimulate the back of the oropharynx and cause vomiting. So these are inserted with the end pointed up to the roof of the mouth. About halfway back, give it a turn, and it falls in place behind the tongue. If he gags on it, pull it right out right away. People that are unconscious, this is an airway model, and all that's happening with these folks is everything is just falling to the back of their throat because they're unconscious and blocking off the air passage. It's that simple. Your OPA, when it's in place, just gets behind the tongue and stops it from closing. It maintains an open airway. And that's how that works. An unconscious person's jaw will move about this far side to side and about this far in and out. But when you're conscious, all the muscles are taut, and you can't do that when you're awake. When they're unconscious, that's what you see. So we've got our airway controlled. We don't know exactly how long this guy's been down. We want to get the BVM on him right away and get some breaths into him. We only got 4 to 6 minutes before his brain starts to die. The way I like to put these on is to flare out the mask, put the tip on the bridge of the nose, and let it fall into place. You got the C grip, where you're pushing down, and the other 3 fingers are pulling back on the jaw to keep the airway open. You give a nice, slow, even breath. You want to deliver your breaths about 6 seconds apart for the first 30 seconds. That equates to about 5 breaths. We'll give him one more. As soon as you stop, check for a pulse. 5 to 10 seconds. Make sure it's still there. And it is. He's been oxygenated now, so that bought us some time. The oxygen tank is still set up. We pull the mask off, plug in the BVM, and this we're going to run at 15 liters. Got to fill the bag, we've got a large space to fill, and it has to keep up with your respirations. Don't wait for it to refill. Get your mask seal again, open the airway, and start ventilating. And you should get a chest rise. This time we're going to go for a minute or 10 breaths. Watching for that chest rise. Chest rise is critical. If you don't see a chest rise, you get a mask leak, you're not getting much at all. This is something that you have to stop and fix. You have to get a chest rise or he's not going to breathe. It's absolutely critical. If he vomits again, you're going to have to quickly stop, pull your airway out, and suction. Far back as you can see, suction till clear. Measure your airway again. Control the tongue, insert and continue. So whatever might go wrong, you might lose your head tilt, you might vomit, you get a mask leak. Whatever your problem is, you have to fix it. And it's not an option. If you don't fix it, this patient isn't going to breathe. If he doesn't breathe, he's not going to live. We give 10 breaths, 6 seconds apart. Watching for that chest rise and fall. Good seal, good C grip, keeping the airway back. And the question you want to ask is, how can you tell if the patient is being adequately ventilated? And the best answer is a chest rise. Depending on what happened to him prior to this, you may see his color improve. And if it's simply a respiratory arrest, you might see some spontaneous breathing start up. If that's the case, if he gags on the airway, remove it, but keep your airway open. When he takes a breath, you give him a breath. If he doesn't take one in 6 seconds, you give him one. If he inhales, you give him another one. You got to match up your movements with what respiratory effort he's putting out. If he doesn't take a breath in 6 seconds, give him one. Usually if they start breathing on their own, you don't necessarily need the OPA because he's oxygenated to the point where it's going to gag him. You have to play that one by ear. So as soon as he starts to breathe in, we're going to just follow. And you got to work with him. If he wakes up, you could talk to him and tell him you're helping him breathe. And just tell him when you take a breath, I'm just going to assist it. He might fight it, but you can tell him you've got 100% oxygen going here, and it's the best thing for him. You got to kind of sell it. After a while, he'll believe you because it's working, and he's being oxygenated. You can develop your own grip and technique to do this. This is the way I do it. As long as you get a seal with a mask and a chest rise, you can make your own adaptations to how you hold the bag or do the ventilations. This is just my way, and it works well for me. As long as you get a chest rise and maintain the seal, you're golden. All right, thanks for watching and be safe out there.